All right, we are live, and thank everybody for joining us. We got a great discussion today for Black Men's Health. If this is your first time to Black Men's Health, we are absolutely focused on creating more balance through health for men of color, specifically Black men. Have Dr. Donald Alcendor on the call today, as well as Dr. Derek Griffith, and my true blue Ace Callwood, and I trying to manage all of the traffic control along the way. So before we jump in, I'm going to give just a little brief intro for Dr. Alcindor and Dr. Griffith, and I'll let them take it from there because they can definitely do a better job than me just reading scripts. But we always want to give them their due, but at least to make sure you know who they are. Dr. Alcindor is an associate professor, Center for AIDS, Health Disparities Research Division, Microbiology, Immunology, Physiology, Obstetrics, and Gynecology at Meharry Medical College. That's a lot, and he's got a lot to share. So we appreciate him being here. And Dr. Griffith is a professor of medicine, health, and society. He's also the founder and director of the Center for Research on Men's Health at Vanderbilt University. And he has some big news and transitions coming up in the near future. In July, he'll be headed to Georgetown, so we can hear all about that if he'd like to talk about it, or we'll just talk to him in the future on that. But with that, Dr. Alcindor, why don't you go ahead and give them more about who you are, what you've been doing, and we'll do the same thing with Dr. Griffith.
Yeah, so like you said, I'm at Meharry Medical College, and I studied at Johns Hopkins and got my Ph.D. in UC Davis. I've been doing virology for some time. I'm a molecular virologist by training, and COVID-19 is certainly something that would be on my radar. So I've been looking at this. I've been writing about this. I've done about 75 different radio, podcasts, newspaper, magazine articles on COVID-19. And of course, I'm developing a COVID-19 antiviral at Meharry. It is going to be very unique in a sense where it would be specific for COVID-19. Unlike some of the other remedies for COVID-19 that are non-specific. And so the only antiviral that's out there right now is remdesivir, and it has had a clouded history in terms of being effective in dealing with this infection. But what we have is something different. And the idea is that our strategy is to go specifically at the virus and develop a reagent that would be effective regardless of if you have a variant as well. And so I have targeted the PP1A and the PP1AB gene loci of the SARS-CoV-2 virus. And if you're able to target that particular loci, you're able to shut the virus down in terms of its translation and transcription ability to where it just cannot survive. And so, and choosing that particular loci, that is a loci that does not undergo hypermutation. So you would not see the evolution of variants at that particular gene locus, making it a very unique antiviral that I think would work in a matter of hours after administration. And of course, we have to deal with toxicities. We are at the level of looking at this with animal models. Another thing that I've been doing is getting out on the street, boots on the ground, so to speak, talking to the folks in Nashville, barbershop, salons, small businesses about COVID-19, because we have to get this vaccine. And of course, not getting this vaccine in a lot of ways is not an option. The idea is if we want to get to herd immunity, we have to get vaccinated, and the time will come when our children will have to be vaccinated as well. If you take out children, you're taking out about 20 to 25% of our population here in the States. That would put us at about 80% vaccinated if every adult were vaccinated. That would still leave us just right at herd immunity. So we're likely to have pockets of anti-vaxxers throughout states in the United States that will allow this virus to continue to smolder and transmit and result in the evolution of variants, and maybe, just maybe, a hyperimmune variant that is not susceptible to our current vaccines. And so that's one of the concerns that I have now going forward.
You got the big work going on, sir. We appreciate all the work you're doing, Dr. Alcindor. We're going to jump back into a lot of that as we talk today about health justice, past, present, and future. Dr. Griffith, if you would expound a little bit, tell the good folks who you are, what you've been doing.
Yeah, so I've been studying men's health, particularly Black men's health, for probably, that's going to date me if I say how long, but let's just say 10 years, a little more than 10 years. Looking mostly at the combination of sort of gender factors and what is unique about the ways that Black men sort of approach health and well-being, and trying to understand that as a foundation for understanding how we can better engage Black men in efforts to improve their health and well-being. I came to COVID really through that sort of lens and trying to really understand it from the perspective of men. And really, one of the things that has been an issue since the earliest sort of studies outside of the United States, in China and Italy, is that men have been dying at far higher rates of COVID than women, independent of how much they were necessarily contracting the virus. So it wasn't that they were contracting it more, it's when they contracted it, they were dying at higher rates. And we didn't understand and don't necessarily understand, well, Dr. Alcendor probably understands why these things are actually happening. I know it has something to do with the chromosomes and so forth, but the point is that's how we sort of entered it from the psychosocial space, if you will. One of the things that I think is, and so in the States, we focused much more on developing the vaccine. For me, we've spent less energy and effort into figuring out how we need to roll out the vaccine and really engaging folks to figure out why are they hesitant, what are their issues, what are their barriers. In anecdotal conversations, folks who have wanted to get the vaccine have found it difficult to do, difficult to navigate the systems and so forth. So it's not just about sort of hesitancy in and of itself, but it is something that we, have to sort of think about what are those other sort of practical issues. Last thing I'll say is sort of entering this conversation is, that we have treated as though the only option, it is certainly the option that we've gone with in the States to focus on vaccines, vaccinations, and so forth. There are policy options that we chose not to use to actually look at how do you contain the virus. If you look at, and the model I'm thinking of is New Zealand, that basically really shut down. They used more policy, and they really did a great job of actually managing the virus by actually, having people, adhere to the rules of staying in their home, wearing masks, doing those kind of things. And within a couple of months, they actually didn't have any active cases, and they've had very low active cases in their country since the beginning of this global pandemic. So the point here is that there are other options. We chose not to do that in the States for whatever political and other reasons that we chose that approach. But it is noteworthy that some of this could have been mitigated by making choices around policy levels that we need to really consider.
Agreed. New Zealand's been chilling. They're just rocking out like it's 2019. We are all, we are all jealous of the sacrifices that were made so they can be in that situation now. And as you said, in the States, for so many different variables and reasons, we are not there, which is unfortunate, and still seeing spikes in certain areas. Ace, brother, jump in. Tell the good folks who you are. Hang on. I'm
going to
take you off mute, Ace, because we need to hear you.
There we go.
There you go.
I promise that I'll talk to myself on mute once a day. I didn't expect this to be the
just one,
but it is.
Just one.
I got it out of the way. So those backgrounds really helpful. I mean, both of you, particularly through COVID, have been hyper focused on your work, our community, and how we navigate a globally traumatic event that has highlighted the inequity in healthcare. Is maybe a way to frame that. So I want to go back. I mean, as we're talking the past, the present, the future of health for our community, I want to start and help me understand some of the foundational building blocks of why we are where we are. Dr. Alcendor, before we got kicked off, part of what you were talking about is the Black medical community and the educational opportunities or the lack thereof for us. So can we go back, the past, call it 100 years, and let's start building a foundation of why we are where we are today before we start talking about how to fix it.
Yeah, I think you have to go back to the Flexner report. This was Abraham Flexner that got the opportunity to go out and to review Black medical schools in the United States back in 1910. And so what he found, looking at 14 Black medical schools that were established, many of them went out of favor and basically was no longer in existence after 5 years, most of them. And so what he said in his report is that there were certain medical schools, and he was talking about 7 of them. 5 of them, he stated, they were not able to contribute significantly to society. And he also said that Black medical schools needed to be there in order to help Black people. And of course, the way he framed this is that there were 60 million whites and there would be 10 million Blacks associated with these whites. And so that wasn't clear to me the way he stated that. But remember, this is 1910 that we're talking about here. Now, of the last few medical schools that he felt was in favor of being able to be successful going forward, there was only 2 Black medical schools he decided that were worthwhile keeping and supporting. And that was Meharry Medical College and Howard Medical School. And the idea here was they would be able to contribute, the others not. And just because of that report, you saw a tremendous reduction of Black medical students, Black people going into medical school at that time, with a precipitous increase in the number of white students that entered medical school at that time. It was not until 1966 that you saw other Black medical schools come on board. In this case, Drew University in California, and of course, subsequently that Morehouse College. And so what I'm saying is that Black medical schools and providing those people, those professionals to take care of those individuals in our communities have been, had a troubled past and have had a difficult time. And that's why we only have 4 existing Black medical schools among the HBCUs that have been given the task of providing the mainstay, the lion's share of Black medical professionals in the United States.
So let me jump in and ask the obvious question. I think because we work in health, we know the answer to it, but I want to get words to it. Why does that matter? Why do I need a Black physician? I have a body, everybody else has a body, and anybody can solve my medical problems, right?
Yes. So it's about context.
Okay.
It's about giving people information in the context that they can understand it. It's about trust, meaning that, somebody that looks like you, experience things that you've experienced, again, makes you feel somewhat more at ease about giving them information about your health and trusting them to execute whatever it is to improve your health. Another thing that's very important that we've seen is that the information is coming out showing that Black physicians that have taken care of young babies compared to white physicians over a certain period of time, they've seen reduced mortality in those individuals that were taken care of by Black physicians. And of course, again, the way that the institutionalized racism that is part of the medical establishment is something that has been rooted in society for such a long time. And the idea of being able to deal with that overnight is something that is going to be very difficult to do. I mean, everything that we are trying to do is well-intentioned, but you are trying to deal with decades of inherent racism that is not easily overturned by policy even.
Sure. So I want to jump to Dr. Griffith because, a professor of medicine, health, and society. Sounds like we were talking about the nexus of your bailiwick. Talk to me. Does this track? Is Dr. Alcendor on point? What's your take on where we are and why we're here?
Yeah, so let me start from, there's no doubt Dr. Alcendor's on point. But let me start from sort of the health profile and sort of the epidemiologic pattern and sort of marry that with where Dr. Alcendor sort of comes in. So we've known basically for as long as we've had data in the United States that Black people die at higher rates or have a shorter life expectancy than white people. What's been interesting, though, is if you look at the data from about 1900, the gap between men and women, say black men and women or white men and women, was relatively small. It's actually grown over the course of the 20th century, and black men have continued to fall behind and not improve their health at the same, or their health has not improved, and their life expectancy has not improved at the same rate as other groups like black women or white men or other, genders and racial groups when you look at that intersection. And so the question is, we've always known that there's a racial disparity, and we pay attention to that. What we don't usually pay attention to is the intersection of race and gender, and why it is that black men are advantaged in our society, because we make more money than black women, we don't face sexism, we don't have all the barriers that are structural barriers like that, yet our health tends to not benefit from that in the same way, meaning that we don't still have the same life expectancy. You would usually having more advantages or having less of these disadvantages for most other relationships tends to actually lead to better health. That group that doesn't face those challenges tends to actually do better. Black men and men's health in general, and black men in particular, we know that that's not the case. And that's been one of from the intellectual side, that's why this is such an interesting issue and problem. So when you bring that sort of that context to COVID, and we know that black men have higher rates of mortality from things like heart disease that, COVID very much, basically builds on. If you think about the issues with comorbidities and so forth, it's usually related to things like obesity, heart disease, diabetes, and those kind of factors that COVID feeds on. I'm going to let Dr. Alcendor speak to the more technical ways of that. But in my language, it likes those, it feeds on them. It basically, if you're thinking about who is actually dying of COVID, it's those groups that have those kinds of diseases. And a lot of those they're stress related as well. Where I'm going with this is you have to look at, and even in the United States, black men have been not only dying at higher rates, but actually what we've seen from the preliminary data that looked at life expectancy in 2019 versus the first half of 2020, usually life expectancy has increased generally over time or it's kind of stayed flat, meaning that the life expectancy in a particular year, when you look at the next year, usually is about the same or ticks up just a little bit. 2019 to 2020, we saw a dramatic decline in life expectancy for all groups, but particularly for black men. Black men's life expectancy between 2019 and the first half of 2020 dropped by 3 years.
Yikes.
For black women, it was, I believe, 2.4 years. I believe it was white men. I'm not going to remember which other groups, but there was another group that was 2.3, 2.4. The closest other groups were more than a half a year better, if you will. And then some groups lost less than a year. So if you put in context the fact that we were already doing the worst, we already had the shortest life expectancy, we have the highest rates of dying before retirement age of any race by gender group, that it's understanding the historical context of what is it about being black and male that we have to better put together and figure out how medicine, public health, and other entities can bring together and support us as black men in our health and well-being.
Yeah. So I love the reference to Kimberly Crenshaw's body of work and intersectionality, right? We've got multiple identities and they're all interrelated that we have to navigate, particularly as black men. We've got an inordinate amount of privilege in some areas, particularly over women, but we face some of the same systemic pieces and inequity across the world we exist in similar ways as well. And so navigating that's tough. It sounds like are you going to jump in, Dr. Griffith? Go ahead.
If you don't mind. Yeah. But I think one of the things that is different, so it builds on Kimberly Crenshaw's work. And if you look into the nuances of it, that it definitely, she spoke to this, but it wasn't sort of the primary thing that she was focused on. When she originally identified it, it was basically saying that if you think about, without sort of simplifying this too much, when she originally came up with this idea, or I shouldn't say came up with it, when she originally coined the term and built on this body of work that Black women in particular have been identifying since Sojourner Truth and others over centuries, or certainly over decades. So they're very clear for those in this space are very clear that she didn't, really come up with the term, but she just kind of built on a body of work. So that's what I was kind of backtracking on. But the other part of this is, one of the things that she sort of talked about was she couldn't, the whole reason she came up with it as a legal scholar was because she couldn't bring cases of employment discrimination for Black women because they were Black, because Black men were employed in that sector. She couldn't bring it based on gender because white women were employed. So it was basically, there were two markers of oppression, disenfranchisement, what have you. What makes Black men's health a little different is you have one marker that's necessarily negative, and you have the other that is that's a benefit. And so there's a scholar named Adia Wingfield, who's now at Washington University in St. Louis, who wrote a book called No More Invisible Men. And it was about the idea of looking at more successful, economically successful, and professionally successful Black men. And she highlighted, why is it basically that we know that from a health standpoint, Black men don't benefit from their education, employment, economic sort of success in the same way in terms of their health profile doesn't appreciate as much as it does for other groups. Where I'm going with this is simply to say that there's the combination of advantage, disadvantage, what she called partial tokenism, because when you're Black and you're sort of in successful spaces, that you're usually one of very few. And so you're hyper visible. There's a lot more stress on you. There's a lot more context to what you're doing. And if you think about that, in addition to it balances out or even negates the benefits that come with gender. So it's a different take on intersectionality that we have to, when we think about it in relation to Black men and Black men's health, we have to kind of work with it in a particular way that applies it slightly differently than what her original intention was.
Aptly put, and appreciate the context. I think particularly as we have the Black men's health conversation, that nuance is important because we throw the blanket term intersectionality out and think about, we don't talk through the nuance. And so lending some credence to that is really, really helpful. Part of what you shared, Dr. Griffith, in talking about Black men and where we are right now, and then the Black community, really, the comorbidities that are exacerbating the experience of COVID. For us, we got there somehow, right? The inequity that is not just health, it's all health related, but didn't come from health necessarily. It came from the economic plight and some of our living situations, and the as I think about redlining and some of the pieces that foundationally got us to a place where now we typically have worse health conditions and diabetes and heart disease, so on and so forth. How did we get there? What led to our community being behind the eight ball going into a global pandemic?
All of these social determinants, Ace, right? These social determinants.
Social determinants of health cannot be kept out of this conversation. You see what I'm saying? Meaning that your current opportunities when it comes to education, where are you living? How are you living? People that are living in multi-generational households, even those that are living in these multi-generational households that probably are undocumented. These are people that are not going to go out and get health care because they feel that immigration officers will be waiting at the doctor or at the vaccine distribution center for them. And so I think you cannot ignore social determinants of health. When we look at those individuals that are at the interface of being highly susceptible to COVID-19, we make up people that work in grocery stores. We make up the majority of people that work in warehouses, meat packing plants. You see, Black and brown communities work in occupations that put them at the interface of COVID-19 transmission. We don't have access to PPE on a regular basis. Of course, along with all of that, we have conspiracy theories that we have to shake off in order to deal with this epidemic. This concept started very early in this pandemic. The idea that the melanin in your skin was a protective factor against acquiring COVID-19. From a scientific standpoint, to me, that's outrageous. You see what I'm saying? And the idea is that some people will hold on to these ideas for a very long time. At the same time, you have these anti-vaxxers that are out there that are promoting, and again, they are financed as well quite nicely these days. They are promoting problems associated with vaccine safety. If we look at vaccine in terms of what they have done over the years, let's talk about that, because I think it's very important. I'm always talking to mothers who are very concerned about vaccinating their children for COVID-19. And I talk to them, I say to them, do your children go to public school? And they tell me, yes, they do. And I say, I don't know this, but to go to public school, you have to be vaccinated, and your vaccine records have to be updated every year to enter public school.
Right.
I told them also that, do you know that your children have been getting vaccines from birth? Your first vaccine, you're 2 months old when you get your first vaccine. Now, just a little bit of the history of vaccinology. In 1960, we had 5 vaccines here in the United States for you to take: polio, smallpox, diphtheria, pertussis, and tetanus. Only 5 in 1960. In 1983, you had 24 vaccines. In 1986, something very important happened. The National Childhood Vaccine Injury Act was passed, and that increased vaccine schedules to where it is today. From being born to being 18 years old in the United States, you get 74 vaccines. And so the idea is that we have been getting vaccines for a very long time, and vaccines have basically added 30 years to our lifespan in the last 100 years.
Wow.
You see what I'm saying? If you think about all the children that you would have to give back because of measles, measles kill children. You see what I'm saying? Measles is not just a rash that comes out of anywhere. Diphtheria kills children. You see what I'm saying? Diphtheria was a reason why people had to get a tracheotomy back in the day before a vaccine. Can you imagine that? And imagine all the children that would have died of polio. Smallpox was a debilitating disease. You have to go back to the 1950s to understand the seriousness of smallpox. You had to have your child vaccinated in the United States before that child was 3 months old, or you would be faced penalties in terms of imprisonment and fines. At that time, there were compulsory vaccinations, meaning that you had no choice if you wanted to live in the United States. And that became the birth of the anti-vaxxers. So vaccines, when you look at them on a whole, they have been the most scrutinized public health interventions of our time, just because they're so widespread. They undergo as much or more scrutiny by the government, by scientists, than any drug that is in your medicine cabinet. And so the inconveniences of vaccines in terms of side effects are relatively small compared to what would happen without these vaccines. So vaccines have a history, and they have had an effective history for decades, and will continue to do so as well.
Dr. Alcendor and Dr. Griffith, right? Because I know Dr. Griffith and I have talked a lot about mental health in the past, which is critical in a pandemic, and not only a pandemic, but also, you know, just social, I call it social awakening. Some people call it social uprising of everything that's going on in the world and being filmed daily. Not that it has been new, it's just been captured more with all of these social justice issues and criminal injustice issues and racial injustice issues and things of that nature. Let's talk more about hesitancy, right? I mean, you know, obviously there's some people that don't believe in science, period. That's difficult for me because I'm an engineer. I'm solid at math, so numbers are numbers. It doesn't really matter how I feel. I used an example to somebody recently. You know, I'm cooking popcorn with my son, and a kernel. Right, I got a whole pan full of popcorn, and one popcorn kernel kind of falls in the little, you know, grate, and I think I could get my hand under there. Right, just a moment of, you know, silliness. I reached under there, and it burned me. Right, and I did it again. And my son looked at me. He gave me the face that I give him. Right, like, what are you doing? right? In my mind, I believed that I could navigate. That's why I did it the first time. I wanted that popcorn, even though I got all this popcorn over here. I wanted that one popcorn, and I had the belief that I could navigate my finger to get that. But it doesn't matter, because science says every time my finger touched or got close to hot metal, it was going to burn me. Period. Doesn't matter what I believe. Didn't matter how fast I was or how agile I thought I was. Right. So it's difficult for me in a lot of this, non-believer in science, but in our communities related to the hesitancy. How do we combat this, right? I mean, I go out and, even with the recent CDC guidance in the sense of you can, anybody can basically not wear a mask outside. I think that's going to be challenging because the natural movement of when you're outside is to go inside and go outside and go inside. So that's going to be, I think, a great challenge. But how do we combat this in our communities? Because, I could go somewhere and there's, a lot of people that just are acting as if we're in 2019 or as this is over. So how do we communicate to our communities of color that we need to get vaccinated? We need to, hopefully when we have a solution for our children, make sure that, as Dr. Alcendor said, get another vaccination so we can, help bring things back to normal. What are your thoughts on the mental issues, Dr. Griffith, and then we can hear back from Dr. Alcendor.
Sure.
Well, I think so. I'll speak quickly, but I also want to hear Dr. Alcendor talk about, I don't think we ever talked explicitly about why men actually have higher rates of mortality from COVID. Yeah. And the other thing I'm going to ask you to talk about, if you don't mind, is how the stress of what you were talking about, John, from the beginning, the fact that we're in this, not just global pandemic, and the stress that comes with that. Are you going to get it? Are you not? Are your family members going to die and all that kind of stuff? But then the racial reckoning, the stress that comes with constantly seeing this, that at least my understanding of how viruses work is a lot of times the more that your immune system, stress compromises your immune system and increases the likelihood that you're going to contract something. And so the fact that we're Black men are seeing ourselves in these constant events of those looking like us, those looking like our sons, our nephews, or what have you, that they're dying at these rates and in these horrific ways, that's also contributing to why we're actually dying at higher rates of COVID. Yeah. So it's the stress of, so one of the things that's important, I think I was trying to help put together is, if you think about the structural racism that we were mentioning just a minute ago, and you think about the virus and the pandemic, part of what it feeds on is the pre-existing conditions that you have of who is most likely compromised because we have higher rates of stress, because we have higher rates of heart disease, because we have higher rates of obesity than other groups of men. Those it's this perfect storm of things. It's not just one thing or the other. But if Dr. Alcendor, if you can get into how I don't want to get too technical, but there's a science to how these pieces fit together. Yeah.
Dr. Alcendor, before you start, to your point, Dr. Griffith, there's a recent famous line with Dave Chappelle where I think he was talking about Chris Christie, but he was specifically talking about COVID was like, like I have so much to eat on, right? So when people kept talking about these pre-existing, conditions and things of that nature earlier, or they were saying using other terminology, but basically they were talking about pre-existing conditions. So, as Dr. Alcendor said before, all of these, continual challenges, physically, mentally, all these social determinants were already there. COVID is just exacerbating these things. Go ahead, Dr. Alcendor.
Yeah, exactly. And so there's two papers I recently wrote, one on the comorbidities. And so I wrote this because I was turning on CNN and all I was hearing about is people saying, look, if you got brown skin and you're walking around with diabetes or hypertension, this virus is coming out to take you out, and giving us no reason why this is happening. So I felt that I had to write about this. And so I went into the technical language of just explaining to people why having diabetes would make you more susceptible to the more severe symptoms of COVID-19. And so I'll start with something like diabetes. And so when you have diabetes and you get COVID-19 and you go into the hospital and you undergo this so-called cytokine storm, which is basically an inflammation hurricane that you experience when you get infected with COVID-19. And many people that will not do very well will experience this hurricane in a very serious way. And depending on how long you have this hurricane will tell you how serious your condition will be going forward. And so this cytokine storm, the ideal thing in the clinic that they will give you is corticosteroids. And steroids are very good at bringing down inflammation very quickly. You see what I'm saying? But again, it is the side effect of these steroids that give you problems. When you give a person steroid, it increases their blood glucose levels to alarming rates, even if you're hypoglycemic. You see what I'm saying? Now, this increased blood glucose has been associated with liver injury, a lung injury, and it's also been associated with your inability to clear a virus by your immune system. So the idea is that the consequence of steroid use for inflammation in a diabetic patient with COVID-19 now becomes a part of the seriousness involved in getting more severe disease. Now, if we go to hypertension, you've got a situation where African-American men on a whole, again, if hypertension was addressed on a global scale, it would change the lives of African-American men overnight, because hypertension is associated with cardiovascular disease. It is associated with end-stage renal disease. It is associated with diabetes. If you were to hit hypertension with simple hypertension medications, you would knock out 3 of the prevailing challenges that African-American men face today, and that is cardiovascular disease, renal disease, and diabetes, meaning that you would do more for African-American men by putting them on global medications for hypertension. One of the problems with hypertension medications is that it often will cause problems with erectile dysfunction. And so some people will opt out because of this particular side effect. Again, if we go to hypertension, like I was saying, the reason why you get more serious disease with hypertension is the buildup of a product called angiotensin 2. It turns out angiotensin 1, that is converted from angiotensinogen from the liver, that's made by the liver, and converted to angiotensin 2 by the renin in the kidney, the upregulation of angiotensin 2 because of SARS-CoV-2 binding to the ACE2 protein. So you have the sequestering of the ACE2 protein, leaving a buildup of angiotensin 2. Angiotensin 2 is usually converted to angiotensin 1 through 7, which is basically a very good molecule in terms of not causing inflammation and other problems like oxidative stress and fibrosis. But the buildup of angiotensin 2 causes an increase in fibrosis, an increase in blood pressure, an increase in oxidative reactive oxygen species that can result in multi-organ dysfunction. Many patients with COVID-19, when they're in a bad shape, they have multiple organ distress, multiple organ dysfunction that includes not only the lungs, but includes the heart and other visceral organs. And when you are at the stage of multi-organ dysfunction and you have to undergo mechanical ventilation, you're basically fighting for you to survive at that point. And so when we get to heart disease, if you have heart disease, it turns out there is ACE2 protein expressed on the surface of cardiomyocytes. The COVID-19 virus directly infects heart tissue, leading to the death of cardiomyocytes. So those individuals that have an abnormal echocardiogram, high levels of troponin 1, and of course of advanced age, these are the people that are at the greatest risk of mortality when it comes to COVID-19 infection and disease. And now we go to the last thing that's very important, and that is lung disease. So African-American men are smokers. We know that. And the idea is that if you smoke for a long time and you have developed COPD, asthma, or interstitial lung disease, you are at the greatest risk, because when the lungs are already compromised and you have a virus that targets the lung, and again, the way this virus targets the lung, it gets into the upper airway. Then it wants to find the lower airway, and it's looking for one particular cell type to infect and destroy. And that is the type 2 pneumocyte that is a resident cell in the alveoli of the lung. When this type 2 pneumocyte is infected and is destroyed, you get the accumulation of pro-inflammatory cytokines being expressed. Then those alveoli that are important in oxygen exchange to the visceral organs are dysregulated and dysfunctional. And if you have enough of them to where they're damaged, that individual becomes a candidate for mechanical ventilation. Mechanical ventilation, depending upon how long you're on it, it will reduce the likelihood of your survival by 70%. And again, it depends on the hospital you're in. If you're in a hospital in India and there's no oxygen, you can see that's going to be a problem. So there's no opportunities for mechanical ventilation. And so all I'm saying is that this virus is very deliberate. It will infect you, and it is trying to give you a fatal pneumonia. Even in those individuals that are asymptomatic, in a 15-year-old that gets COVID-19, a 20-year-old, more than likely will be an asymptomatic infection. They've done CT scans on these young individuals and found they have evidence of lung scarring and scarred tissue in the heart as well. Will these individuals over time develop abnormalities in the future related to having abnormal arrhythmias, or for that matter, end-stage pulmonary disease in the future? And so this virus leaves things behind that we don't know about. And the idea is that getting vaccinated is the way to leave this virus behind for good. There's a lot of things that people want to talk about. This virus could be with us for a time.
Yep.
There are vaccine contracts right now that go out to 2025. You see what I'm saying? And they're estimating we're going to spend $157 billion to deal with this virus in 5 years. And so vaccine inequity is another issue that has to be talked about on this program. You're looking at a situation where countries that have money make up 17% of the global population. They're sitting there with 60% of the vaccine supply. You're looking at a country like Canada that has 38 million citizens. They are sitting on 100 million vaccine doses, whereas Nigeria, with 220 million citizens, have very little access to vaccines. You're looking at people in South Africa that are involved in packaging of the vaccine and simply cannot put it in their arms. Can you imagine that? This is outrageous. The idea is that we are not a United States population. We are a global population.
That's right.
COVID-19 will go when it leaves the world, not when it leaves the United States. And the idea is that we have to approach this the same way we did polio and smallpox that are now eradicated. We have to have a global cooperation, a global approach to this pandemic, or it will never leave our shores. Where do you think the UK variant came from? What about the South African variant? With travel, trade, and commerce, these viruses will make it to our shore. We have homegrown situations as well, where you have people that don't want this vaccine, that are hanging out in these small reservoir populations throughout all the states in the United States. And the idea is that they will continue to transmit this virus. And over time, this virus will continue to evolve. You will have new variants and maybe a variant that we won't be able to deal with our current vaccines. And of course, it's going to be very expensive to chase this virus. Viruses are very smart. And the idea is that if you chase them in the wrong way, you're going to increase the likelihood of...
Uh-oh, cut out on me.
Lost some connectivity. Dr. Griffith, I saw you coming off mute and I was heading to you, as it were. So anything to add to that? I know those were kind of some of the areas you wanted to dig in before we transition to talking about what we do, what the future holds. Any commentary from Dr. Alcendor?
Well, I think, I mean, he's definitely, right on. And I think the getting into the specifics of how it operates and so forth, I know may have been difficult to follow for some, but I think it's important to have that depth of understanding. I think the other thing that we were talking about as it relates to hesitancy, which I think John, I think you were going a little bit ago, is some of it to me is as basic. Well, one of the things that, again, we need to focus on hesitancy and people who actually have access that choose not to get it. But I think we also need to recognize that not everybody who wants it does feel like they have access to it and is willing to go through the headache to figure out how to get access to it, to then be able to get the vaccine and then get both doses of it. So one of the things that's been challenging for some is, how do I navigate the system to even get on the list to be able to go get the vaccine? In a lot of places, that has been very difficult to navigate and make sense of. It hasn't necessarily been easy. It hasn't necessarily mapped onto regular schedules for those who are going back to work, even if they're working from home. It's been difficult to sort of navigate those times when you're supposed to be working and to get access to those treatments. So I think there are a lot of those kind of very practical things that we need to take into account before we get to that. The other thing at just a basic level with the hesitancy is, a lot of it to me is just basically because people don't like being, in the United States, we don't like being told what to do. And some people's just basic, you know, I'm grown, right? I'm grown, and a lot of I'm not a Republican. I'm not a right-leaning person, but I do understand the idea that a lot of the hesitancy, or at least some element of it, let me say that, is the fact that the government is telling them what to do, and they don't like being told what to do. And it doesn't matter if they're telling them to basically, you know, whatever it is, they're not going to like it because they're being told what to do. And so we have to find better messaging around how do you get past the idea of, okay, regardless of whether we're telling you what to do, you need to find a reason to do it for you. Don't argue with me about, okay, yeah, they should have or should not do this to X, Y, Z. That's fine. Whatever. That's not really the point. The point is, this will save your lives, the people that you love, the people that you care about. And regardless of what your issues are with who's mandating and encouraging it, whatever, is it something that is a benefit to you if you get past that issue? And so I think we've got to, yes, sir.
Real quick, I'm sorry to interrupt you. The messaging piece, I don't want it to be lost on anybody, right? It's so important. I'm a communicator, right? I'm a professional communicator. And when the first kind of introduction of COVID came out of how we could protect ourselves, it was, and Ace, I don't know if you and I talked about this. Ace and I have something coming up in the future. It's going to be agree to disagree, right? Ace, we're going to introduce that in the future. So Ace and I can easily get off on a tangent. But this introduction of how do we protect ourselves from COVID, and how do we, be successful moving forward. And it was all this kind of altruistic posturing of like, I'm trying to protect you, right? I'm wearing a mask because I'm protecting you. And I was like, this is ridiculous, right? I mean, because, especially Americans, and they're not thinking about you. You're not thinking about them. They're thinking about me. I mean, I think that should have been some messaging from the beginning, in the sense of how, if you don't wear this mask, you could technically be sliced in half or something, just, like very, very clear how it could affect you, because everything that was based on, I'm going to wear something to protect you, was just lost on so many people. Like, whatever, I gotta wear something to protect you, and it's going to impede on my rights and all of that good stuff. It was the messaging is so important, Dr. Griffith. I just wanted to speak to that.
I think that's a good point, but I think we've also, I guess for me, the fundamental issue is we got to meet people where they are.
Yep.
And we need to better understand and not make assumptions about why people are not getting the vaccine. Some of it may be hesitancy, and they just, are well informed and are choosing not to for whatever reason. I think we jumped immediately to that with the assumption that people actually have good access to this, and I don't think that's a fair assumption.
Agreed.
So I think that's the first part. To your point, there can be nuance to this idea of choosing not to get it for others. So again, anecdotally, I've heard men talk about, or report hearing other men talk about, I don't want to get it because I want to save doses for my wife. I want to save doses for my children. I want to make sure those who really need it are going to get it. And I don't really feel like I need it because I'm not as at risk. I'm healthy, I'm strong, whatever. I would rather make those doses available for them. So I think we have to engage them in a different message to say, well, no, if you get it, you're going to potentially put these people at risk. You're going to put your loved ones at risk. You're going to potentially not only put them at risk because you're in the space and in the house with them, but you're also going to put them at risk because of whatever else it is that you provide as being a part of their lives, you know, just socially, morally, spiritually, you know, financially, all of those things. You're not going to be able to do those things if you are debilitated because of COVID.
Yep.
And this idea of long haulers is really something that I think we are really underplaying.
Yeah.
And,
agreed.
you know, I have colleagues, or one in particular I'm thinking of, who is cognitively disabled now. She has a Ph.D. and a master's degree and a Ph.D., is now on disability because of the symptoms associated with COVID. And we don't talk about these kinds of things and how debilitating this is. Some people's lung capacity is not regained, you know, 6 months, 8 months after. So the reason that we're focusing on vaccination or not getting it is because the other reality is we're better at preventing COVID than we are at treating it. And I think we've got to really appreciate the assumption is if you can vaccinate something that you can actually, you know, I think people's assumption is, oh, since we have a vaccine, clearly that means we're good at treating it and we're good. No, we've figured out how to prevent you from getting it or decrease the likelihood that you're going to get it.
But
we're still not,
right.
But we're still not at the point where we're doing all that great. When people have it and they have all comorbid conditions or they are at particular risk, they're still dying.
Yeah.
And they're still dying quickly, and they're still dying painfully. It's still not something that we're doing well. So the vaccine and doing those kinds of things to protect yourself, to protect the people that you care about, is a really important and fundamental thing. And it is really important to recognize that those issues are not, Dr. Alcendor, I was just saying, one of the things that we're facing now is that we're better, at least in my opinion, at preventing the virus than we are necessarily treating it. And that part of the other reason or motivation to basically get people to get the vaccine is because it's harder to figure out how we're going to treat it, because there's a lot more complication. There's a lot more other factors that go into. We talked about all the additional things that happen when you have type 2 diabetes and obesity and heart disease and so forth. That's a much more complex picture than just preventing it up front. And you put fewer people at risk that you care about if you just get it and you're protected and you're able to protect your loved ones and so forth in that way.
Absolutely agree with that 100%. The idea is that being able to be proactive by getting this vaccine, you're going to protect the people you care about. And the idea of this is very important. Just think about this. Since we've been masking, we looked at the incidence of influenza in the United States. Influenza has been cut down by about 2/3 in the United States. Remember, influenza will take 30 to 50,000 lives every year. Influenza, 30 to 50,000 lives. We have cut that down by 2/3 just with the policy of masking. So what we know is that a mask will work against any virus, any variant. You see what I'm saying? Now, when it comes to these vaccines have been shown to be effective at the majority of these variants. You see what I'm saying? So getting this vaccine is a way of protecting yourself against the virus, the original virus, and the virus that's to come. Again, the vaccine companies are going to be putting out boosters that involves antigens that have been modified to basically accommodate for the mutations that you see in these variants. And so you can see it already. The number of deaths in the United States have dropped considerably. The infection rate is still at about 60,000 people per day. But again, death rates are considerably lower. And now when you start to do this on a broader scale, you're going to see even more death rate going down. And again, what we did that was very important, is we protected those vulnerable populations, people 65 years and older. We protected them. And when we did that, we're able to cut into mortality in a very important way. Doing that ahead of time, in the beginning, this would have made a clear difference.
Absolutely.
So,
And the only thing I wanted to quickly add to what Dr. Alcendor was saying is, for those who may have concerns about the idea of getting a booster or having to get this as a regular thing, think about the idea of the flu shot. The flu shot, the reason you have to get it every year is because the flu changes, the flu mutates, the flu, how it operates. Again, I'm not going to try to get into weeds, and I'm going to let him do his thing. But the point is, this is not without precedent. This is something that we commonly deal with. So don't keep treating COVID and the vaccine as though it's something that's an anomaly. We have vaccines. This is part of our lives. The way that we manage a lot of the symptoms, or a lot of the issues that we have that are no longer, that we don't see as issues anymore, is through vaccination. Yep. And so the idea of getting boosters is nothing unusual. Yeah, go ahead. I'm sorry.
Absolutely. And remember, the booster is to potentiate your immune response. It makes it stronger. In this case, the booster will be used also to protect you against variants in the future as well. I want to say one thing about this concept of long haulers. These are people that have lingering symptoms associated with COVID-19 after they test negative for the virus. We have to address this. Many people are at home suffering with these symptoms: the brain fog, the fatigue, the mental disorientation, the neurological abnormalities, and so forth. The doctors are turning these folks away, telling them that we can't find virus, you should be all right. And again, there are other folks that are trying to develop multidisciplinary teams that will actually try to look at dealing with the individual symptoms. And one thing that has recently happened that I think is very important to talk about on the program today is that people that are long haulers that have decided to get the vaccine, they have seen about 1/3 of those individuals, their symptoms get much better. Some of them, the symptoms go away. However, there's a considerable number of them where the symptoms do not go away, and about 15% of them, the symptoms get worse. And so this is not a one thing fits all approach. The idea is that there's more to know about this virus that's been with us for about a year and a few months. And so we're still dealing with this, and we've always been playing catch up, and this virus has basically made us respected many, many times in the past.
Amen. Well, listen, I know we are at the hour, so I'm not going to hold you all long. You guys both of you have important work ahead, much work for a later period. Obviously, this was a part of our social justice series, our social justice summit related to health justice. We didn't really get a chance to talk about the future, but we did talk about some things that are in the future. I know Ace and I want to bring you all back at some point just to have a much broader discussion. We focused so much on COVID, which has been a part of our, everybody's life for the last year plus, and it should be our focus right now as we work to get through this. But as we know, there's so many complexities and challenges that were in front of us pre-COVID, and that will be with us even post-COVID as we work to come out of this, that we need to focus on as people of color, as men of color, as men, and specifically as Black men. So Ace and I like to thank you all for joining us in this discussion, Dr. Alcendor and Dr. Griffith. And we ask you to give us some time in the future and some more time and attention so we can share with these brothers across the globe and make sure they're listening to relevant discussions from relatable people.
Pleasure.
Okay. Thank you so much. Thank you for having me.
Thank you all.
Absolutely.
Peace. Ace.
Peace.
Love you, brother.
Same. Thank you.